We're honored this year that Dr. John Stone has accepted our invitation to come and speak to us. Dr. Stone is currently professor of medicine at Harvard Medical School and also is the director of clinical rheumatology at MGH. John completed his undergraduate studies at Harvard and has received his MD there. Did a residency in internal medicine at Johns Hopkins and followed that with an MPH at UC Berkeley, and then stayed on the West Coast and did his fellowship at UCSF. John has a long-standing interest in vasculitis and has authored numerous important papers, and one's called the RAVE trial, which has taught us how to use rituximab for ANCA-associated vasculitis and completely changed the landscape of that disease. He's on numerous international and national committees regarding the vasculitis. But also more recently, John has got involved with the understanding and teaching us about IgG4-related diseases. And he'll speak about that today. He's authored over 100 peer-reviewed journal papers and has 4 manuscripts in press as we speak. And he's done much to advance our field of rheumatology. I had the privilege of serving on one of our committees through American College of Rheumatology with John several years ago, and I find him to be one of the kindest people I've ever met. John, it's great to have you here and look forward to your time.
Greg, thank you very much. It's a great honor to be here, to be giving the 2015 Lane Lecture, and a great pleasure to meet Jim Lane this morning. I'm going to tell you about an epiphany that happened to me 7 years ago, and it was in the person of this patient here, this 26-year-old woman from Casablanca. She changed my career and launched me on a course of discovery with colleagues that really continues to this day. Before I saw her, she had seen other physicians for about 3 months. And I asked her, what was your very first symptom? And I'll never forget, she didn't speak great English, but her eyes got very big. And she said, thirst. I was thirsty. So in the course of telling you about this, I'm going to go from this, which is her neck, a picture of which I took the very first day I saw her, to this, which is a model of the pathophysiology of this disease. And I really think it's remarkable that in 7 years we've been able to go from an initial identification of this disease, or recognition by me of this disease, although I wasn't the first to recognize it, to now a plausible picture of the pathophysiology. But before I do that, I have to talk about a couple of prohibitions and disclosures. One of the things I'm prohibited from talking about is this. I promised Greg that I wouldn't talk about this, so it was a heck of a game. And I must disclose that I've had grants and done consulting for Genentech, Roche, and Xencor, and consulting for Bristol Myers Squibb. So now on with the show. This is the picture I took of this woman's neck, and I did not know what this was, and I began to look in the literature, and I went across town to dig up this paper which had been published from Sweden in 1978, and I realized this is something really interesting when I found this man's neck that looked just like my female patient's neck. And ironically, my patient had been referred to me to rule out Sjogren's syndrome. The first author's last name of this paper from Sweden was Sjogren, but not Henrik Sjogren, rather Ingela Sjogren. And the title of this case report gave me an indication that this was a multi-organ disease, potentially. And that case report from Sweden was described primary sclerosing cholangitis associated with fibrosis, remember that word, of the submandibular glands and the pancreas. Still grappling with what this was, I was trying to think back, and I remembered reading about something when I was a fellow called Miklich syndrome. And I thought, I wonder if this patient has Miklich syndrome. So I looked up Miklich's original paper. Mikulicz was a Polish surgeon operating in what was then Germany in the 1890s. And he described this man who had submandibular gland enlargement, parotid enlargement, and his lacrimal glands were so big he couldn't even open his eyes. And I was telling my colleagues about this, and I shared the paper with them. And then one of my colleagues who had been following this patient for Sjogren's said, I've been following this patient for Sjogren's for 8 years, and he looks just like that guy. So I'll come back to this guy when we start talking about treatment in a second. I didn't know what my patient had. I presented her at various division conferences, and finally my colleagues convinced me, look, you've got to take one of those things out. One of those things was her submandibular gland. It could be a lymphoma. So we did, and about 2 weeks later, the pathologist still hadn't read out the pathology. So I went to pathology myself and sat down at the microscope and looked at it. I wanted to know, is this a lymphoma or not? Is this cancer or not? And to my unschooled eyes, it looked like a bunch of mononuclear cells there. And he said, yes, mononuclear cells, lymphocytes, but also up in the northwestern corner here, you see plasma cells. So it's a lymphoplasmacytic infiltrate. And then he made the very strange comment that I'll never forget. He said, it looks like she has autoimmune pancreatitis in her submandibular gland. And that was something also unique for me because I didn't know very much about autoimmune pancreatitis and had to begin to read about that as well. But it turns out that the Japanese, in 2001, published in the New England Journal of Medicine a paper in a disease that was called sclerosing pancreatitis. We now call it IgG4, type 1 IgG4-related sclerosing pancreatitis. And they demonstrated that these patients had high serum concentrations of IgG4 in their blood, and that differentiated this disease from other hepatobiliary disorders. And the Japanese coined a marvelous metaphor for this disease. They've described it as a crow flying through the dark night of medical history. And over the last decade, this disease has been recognized in almost every single organ system. If you're an internist, you need to know about this disease. If you're a physician, you need to know about this disease. And this is that crow, which we now call IgG4-related disease. The only organs that are not involved, to my knowledge, are the brain, parenchyma, and skeletal muscle. Beyond that, you've seen it in every single organ, from the prostate gland to the meninges to the peripheral nerves. So this is what my patient's submandibular gland looked like. There were germinal centers, essentially. Lymphoplasmacytic infiltrate was crowding out her submandibular gland ducts, and that's why she was thirsty. These germinal centers crowding out her ducts. So let's spend a minute talking about what goes on in germinal centers. So very early on, there's an interaction between a young B cell and a helper T cell, following which the B cell migrates to the germinal center where it proliferates, and it is educated by the T follicular helper cells and follicular dendritic cells, undergoing the process of somatic mutation and affinity maturation, teaching it to become ultimately the plasma cell that will produce a single kind of antibody with a single specificity as it emerges as a memory B cell or a plasma cell or a plasmablast. We're going to take a 30,000-foot view of the histopathology in a minute, but I want to speak just for a second about the specific cell types that are involved in this disease, because it is a symphony of inflammation. So there are B cells in the germinal centers where they're supposed to be. These are benign germinal centers. They're BCL negative. They're reactive. They stain for follicular dendritic cells. I'm asked all the time, is this just a pre-malignancy? Do these patients develop lymphoma? The answer is no, they don't. Kappa and lambda staining is invariably performed. It is invariably balanced. there are CD138 positive plasma cells, the majority of which are IgG4 positive. But the most abundant cell in this lesion is the T cell, and it is dispersed throughout the lesion. We'll come back to that. This is what the pathology looks like. This is autoimmune pancreatitis. Here is the pancreatic duct. Remember, the submandibular ducts were surrounded by a lymphoplasmacytic infiltrate. So is the pancreatic duct. And from 30,000 feet here, you can see there's a swirling fibrosis throughout the tissue that pathologists call storiform fibrosis. This is what autoimmune pancreatitis looks like on CT scan. It's a large sausage-shaped organ. It's lost the normal pancreatic markings. This is the disease in the meninges. These are 4 different patients from my hospital with meningeal involvement. This is what the meninges look like when they're biopsied. Again, there's this swirling pathology through the tissue with lymphoplasmacytic infiltrate enmeshed. And this is autoimmune pancreatitis, type 1 IgG4-related autoimmune pancreatitis. I think you can see why one of my fellows said several years ago, this disease is just like sarcoid. Wherever you biopsy, it shows the same thing. It doesn't show non-caseating granulomata, but it shows storiform fibrosis, lymphoplasmacytic infiltrate with a high percentage of IgG4 positive plasma cells, eosinophils. That's what, and obliterative phlebitis. We'll get to that. So once we became aware of this disease, patients started to come out of the woodworks. I was on the consult service, and we were asked by the thoracic surgeons to see this patient who had an aortic aneurysm. You can see the flap here. And this was his pathology. When I heard about the case, I thought, well, this patient probably had giant cell arteritis with occult aortitis. But our vascular pathologist was more astute than I. He noted this lymphoplasmacytic infiltrate within the aorta and said we should stain for IgG4, which he did, and all of the brown staining cells there are IgG4 positive plasma cells. This was the first case of thoracic aortitis associated with IgG4-related disease. And when we checked the serum IgG4, it was elevated to 10 times the upper limit of normal. This is the submandibular gland, lymphoplasmacytic infiltrate. The storiform fibrosis is obvious throughout the tissue. And right here, I certainly would have missed it, but here's another pathology hallmark. This was a vein, obliterative phlebitis, one of the key pathology features, very specific for this disease. This is a disease we all know, retroperitoneal fibrosis. It's caused by IgG4-related disease the great majority of the time. You can see this patient has a ureteral stent in and inflammation around the aorta. This is pathology from that patient, and you can see a normal appearing artery here, but this was a vein. I've outlined its walls in arrows, and you can see the lymphoplasmacytic infiltrate has moved right through the vein, obliterating it. You really can't appreciate that until you do an elastin stain, and you see the normal artery and the vein, which is completely trashed by the inflammation. This is the lung, and this is what the disease looks like grossly, these whitish globules. They tend to congregate near the airways. Here's an airway, here's the disease. Here's an airway, here's the disease. Airway, disease. And this is what we see histopathologically. Here's the airway, and here is the disease, with the same pathology found in every other organ. And this is why we see on CT scan of the lungs thickening of the airways here and here. There's also pleural thickening, which is very pronounced. This disease looks remarkably like sarcoidosis in the lung, actually. These are the kidneys. These kidneys are enlarged with tubulointerstitial nephritis. The CT shows hypodense lesions out in the periphery. And here's the pathology. We know that we're in the kidney because there's a nice glomerulus. There's the swirling fibrosis throughout the tissue. Note the large number of eosinophils in the tissue. Lots of eosinophils in this disease, at least 50% of the time. The disease is remarkably protean. It is a great mimicker, but I want to mention very briefly three presentations. One is mass lesions. I can't tell you how many patients of mine, I think about a dozen, have undergone modified Whipple procedures because it was thought they had pancreatic cancer, or removal of the thyroid gland, or removal of part of the colon and creation of a colostomy because they thought it was cancer. So mass lesions, probably the classic presentation. That patient's right eye was normal. His left eye is markedly abnormal. And this is why. He has an orbital pseudotumor. He was thought by a very good rheumatologist in Boston and a very good nephrologist in Boston to have granulomatosis with polyangiitis, formerly Wegener's, because he had an orbital pseudotumor. He also has maxillary sinusitis, as you can see here, and he had renal dysfunction because of tubulointerstitial nephritis. This is a patient with Riedell's thyroiditis. I remember the lecturer in medical school saying, we don't know what the hell Riedell's thyroiditis is. It's this huge woody growth on the thyroid gland. Well, this is IgG4-related disease. That's what it is. And another proptosis of the left eye. And you can see the proptosis here on CT. The lacrimal glands are enlarged here. They're not supposed to be pooching out that far. And the extraocular muscles are also very thick. This entity called orbital myositis that the ophthalmologists have been sending me for years is IgG4-related disease. The second presentation, constitutional symptoms. 10 days ago, I saw a 32-year-old physician who got sick in November. He started to lose weight. He lost about 10 pounds. He had fatigue. He was working as a hospitalist and really found it challenging to do. He had lymphadenopathy, which was diffuse. The lymph nodes were all less than 2 centimeters. These patients very seldom have fevers, just low-grade fevers. The sedimentation rate is usually very high because of the increased number of globulins in the blood, but the CRP is often not. And patients can lose 25 or 30 pounds over months. And they look well. They really don't look like they should have a sedimentation rate of 110. The third common presentation is atopy. And these kind of atopic features are the classic ones: asthma, allergic rhinitis, nasal polyps, eczema, or an exacerbation of their underlying atopy, associated with peripheral eosinophilia, up to 20% peripheral blood eosinophils and very high IgE in some patients. And this has always raised the question of whether or not this is a Th2-driven disease. We think that it is not a Th2-driven disease, and I'll show you why as I begin to tie the pathophysiology together. But we're going to talk about treatment in a second, but I want to mention 3 predictors of disease flare that we have observed following control of the disease. So these predictors are measured at baseline before the patient begins any treatment. And one of these is the serum IgG4 concentration. Now, in contrast to that original Japanese paper in the New England Journal of Medicine in 2001, IgG4 is not a great biomarker of this disease. In fact, only 55% of the patients in our series of 125 patients with biopsy-proven disease have elevated IgG4 at baseline. But the range is huge, ranging from normal to almost 5 grams per deciliter. Anyway, if a patient has a very elevated serum IgG4 at baseline, they're going to flare again, even if their disease is effectively controlled. This survival curve shows a survival in remission of the highest quartile of IgG4 compared to the lowest quartile. and the highest quartile was associated with a hazard ratio for disease flare of 6.2. IgE is another very good predictor of disease flare, although only 45% of patients have elevated IgE. If they do, if they're in the highest quartile, they have a hazard ratio for disease flare of 8.2 compared to those in the lowest quartile. And finally, eosinophils, although only 25% of patients have peripheral eosinophilia, the hazard ratio for those in the highest quartile is 7.9. So all of these risk factors for disease flare supported the idea, IgG4, IgE, and eosinophils, that this might be a Th2-mediated disease. But we've published 2 papers in the last year, one of which was led by an Italian postdoctoral fellow who's actually an allergist. And he looked at our cohort of patients and he determined that the prevalence of true atopy was actually no greater in our patients than it is in the rest of the population. Maybe more severe, but it's really not more common. And then in a related study, my laboratory collaborators determined that the only patients with circulating Th2 memory cells in their blood, GATA3 positive T cells, were those who had long-standing histories of atopy. So this graph shows it nicely here. Patients with pre-existing histories of atopy were very likely to have a high percentage of GATA3 positive T cells. But those who were non-atopic and healthy controls did not. So this argues that the Th2 is really an innocent bystander in this disease. Now, a lot of what we've learned about this disease has come from observation of patients following treatment. So let's talk about what treatment tells us about the disease. And I want to go back to this patient, these 2 patients here, one from 1892, one from 2009. This patient in the upper left was a 55-year-old man. He had a history of asthma for years, left eye swelling for 8 years, an unusual manifestation of Sjogren's syndrome, which he'd been labeled as having. He had enlargement of his extraocular muscles. He'd been treated with steroids that really hadn't worked. He developed parotid enlargement and lymphadenopathy and underwent a lymph node biopsy and was pronounced to have a reactive lymph node. He was put on methotrexate, didn't work. So we were at a loss as to what to do with him. He was tolerating these therapies poorly. Then we became aware of IgG4-related disease, and we checked his serum concentration, and it was sky high. And these were his parotid glands at baseline. And I've seen a lot of patients who I thought had Sjogren's through the years who had parotids that looked just like this guy's. So we treated him with rituximab. And this was one of many eureka moments. 2 months later, he looked like this, dramatic improvement. And I still remember sitting at the computer with a fellow looking over my left shoulder, hitting return to see what the serum IgG4 concentration was. And only with treatment with rituximab, the serum IgG4 had declined dramatically. And even more interesting than that, this is the point at which rituximab was administered, and you can see this total IgG4 fell. But the decline in the total IgG4 was accounted for entirely by the decline in IgG4. And when one thinks about it, this doesn't make any sense, because plasma cells don't have CD20. CD20 is the target of rituximab. So rituximab should not only affect one subset of plasma cells making IgG4. It didn't quite make sense. So we've developed a hypothesis, and we think we know why. The CD20 positive B cell, the target of rituximab, is important, central to this disease. And in patients with IgG4-related disease, they're all the time becoming IgG4-producing plasmablasts and plasma cells. And these plasmablasts and plasma cells in this disease are short-lived. They're all the time going away, normally. That's okay as long as the B cell pool is there to replenish them. But if the B cell pool is depleted because of rituximab or B cell depletion, some other approach, then the plasmablasts and the plasma cells making IgG4 cannot be sustained, cannot be replenished. And that's one of the reasons we think that B cell depletion works in this disease. So what are plasmablasts? It's a fair question to ask. They're a cell that we're all going to be hearing more about because they're becoming a therapeutic target. But very quickly, B cell development begins in the bone marrow. At about the pre-B cell stage, CD20 is expressed on the B cells, B cell line. Then the development moves to the peripheral compartments, to the lymph nodes, to the germinal centers that I showed you earlier. And it continues to have CD20 all the way up to this memory B cell stage. And here is the plasmablast. The plasmablast does not have CD20, and nor does the plasma cell. And we have identified, looking at flow cytometry of the peripheral blood of these patients, that patients with IgG4-related disease have an enormous concentration of plasmablasts circulating in their blood. Normal individuals it's very hard to find plasmablasts, and even in other patients with other immune-mediated diseases, lupus being one notable exception, you don't find so many plasmablasts. But this graph shows the plasmablasts in patients with IgG4-related disease compared to healthy controls, and recognize this is a logarithmic scale. So there is a huge difference between healthy controls and patients with IgG4-related disease and their plasmablasts. And we use this cell now as a biomarker. It is the best biomarker for this disease. And it's the first rheumatic disease, to my knowledge, where we have a cell that is a biomarker for the disease, as opposed to the sedimentation rate or an antibody. We've performed next-generation sequencing studies on these plasmablasts, and they are oligoclonal, as this Manhattan plot shows here. They are not clonal, they're not malignant. Continuing further on the effects of B-cell depletion, this patient, whom we call affectionately Dr. 414, has taught us more about this disease than any patient. He's a physician, and for 3 years before he came to see us, he had been told that he had lymphoma, multiple myeloma, and pancreatic cancer, all of which, fortunately, were wrong. These are his lacrimal glands. His sublingual glands are so big, they've herniated down through the floor of his mouth, and you can see them there. And he's already had his left submandibular gland removed. In any event, these were his values the day I saw him. His albumin was 2.7. He was slowly dying, had been. His globulin fraction was huge. He was profoundly hypocomplementemic, C3 and C4, and he had a very elevated serum IgE. Because of the overwhelming nature of his disease, we treated him directly with rituximab, and this is what happened. 1 month later, his albumin had normalized, his globulin fraction had fallen, and the improvement was sustained following only 2 treatments with rituximab, no prednisone or other therapies. 18 months later, still doing wonderfully. His complements normalized, his IgE normalized. He felt resurrected, and he gained about 25 pounds because he had lost about 30 pounds over the course of his illness. And he noted that he could now pee like his 18-year-old son because he had prostatic disease too, which was shrunken. This is what happened to his serum IgG4. It fell at every visit, but still abnormal, note, still very abnormal, despite his feeling great. This graph shows the blue line shows his B cells, depleted immediately following rituximab and then returning to supranormal levels. But the plasmablasts in red remained low, despite the fact that his B cells had returned to normal concentrations. And he did well for about 2 years until he developed sores in his mouth. And he called me and asked if rituximab could cause sores in his mouth. And I said, that seems unlikely. You had the rituximab 2 years ago. He came in, and this is his tongue, upper teeth, lower teeth, and he had these terrific ulcers in his mouth that were biopsy-proven IgG4-related disease, a manifestation he had not had before. And on that day, his plasmablasts had bumped up to about 2,000, about 2.5 times the upper limit of normal. But another important point about these plasmablasts, they have undergone extensive somatic hypermutation. You remember that term from the Germinal Center. Extensive somatic hypermutation suggests that these cells have been interacting intensely with a T cell. So we started to look at the T cell population, and we framed another hypothesis about how B cell depletion works. So rituximab is given, the CD20 positive B cells go away, short-lived plasmablasts and plasma cells are not repleted, and serum IgG4 falls. But we also believe there's a profound impact on the T cell compartment, which is the most abundant cell in this lesion. And there is resolution of the cellular infiltrate and a normalization of the glandular swelling, etc. This patient helped us prove that. You can see she has an orbital pseudotumor causing proptosis of the left eye. She has parotid gland enlargement, and she also had skin disease. Her diagnosis was made by the dermatologist who biopsied these erythematous papules and found that it looked like she had autoimmune pancreatitis in her skin, exactly the same pathology. We treated her with B-cell depletion, and 5 weeks later, this is what her skin looked like, with a normalization of her very elevated serum IgG4. So this allowed us to do an experiment. You can see the site of her first biopsy there. This is her original biopsy. Here's the epidermis here. You can see there's inflammation throughout the dermis. That's before rituximab. And this is 5 weeks after being treated only with rituximab. This is a CD3 stain of the before slide, and CD3 stains for T cells, mostly CD4 cells. And this is the T cell stain 5 weeks after. So remarkably, giving a therapy that targets B cells, we've managed to deplete the tissue of T cells only 5 weeks later. So we delve further into T cells, again through next-generation sequencing of the effector T cell pool, looking first at Dr. 414's blood and then other patients. And we quickly found that there was a dominant clone in Dr. 414's blood. It was not a monoclonal spike. There are other smaller clones that you can see here, but he had a very dominant clone. And this T cell, we find that all of these patients have a dominant clone or an oligoclonal expansion of a T cell, which has never been described before in humans. This T cell has never been described before in humans. It makes an unusual set of cytokines. It makes interferon gamma. It makes IL-1, a very strange thing for a CD4 positive T cell to make. It makes other unusual things, perforin and granzyme B, that are characteristics more commonly of killer cells. And it has surface markers that have not been described previously on T cells. So we compared, through next-generation sequencing, these CD4 positive cytotoxic T lymphocytes, CD4 killer cells as we call them, to Th2 cells in patients who had long-standing histories of atopy. And what we found here is the next generation sequencing of the T cell receptor for the CD4 positive cytotoxic T lymphocytes. And there are these large oligoclonal expansions in each patient. These cells have been stimulated and they're replicating wildly because we think they're driving the disease. In contrast, the Th2 cells, there is no oligoclonal expansion. It just, their Th2 cells reflect every allergen they've ever seen their entire lives. So this argues that the Th2 is in fact a secondary phenomenon and the primary process is driven by the CD4 killer cell. Our pathology colleagues developed an in situ hybridization assay for one of the surface markers of this CD4 killer cell, and you can see these little pink spots throughout the tissue of a submandibular gland biopsy, and every pink spot represents the RNA of a CD4 positive killer cell. So this T cell is in blood with oligoclonal expansions, and it is in tissue very abundantly. So this is a model of the pathophysiology now. We believe that the central cell is this heretofore undescribed CD4 positive killer cell. And we think that this killer cell is sustained by its interaction with the plasmablast. We've learned in the last decade that B cells do a lot more than become plasma cells to produce antibodies. They also present antigen. And we think that these plasmablasts are presenting antigen to the CD4 positive killer cells, sustaining them. And when B cell depletion is given, the short-lived plasmablast can't be repleted, and the CD4 positive killer cells can't be sustained. These killer cells are making interferon gamma, they make TGF beta, they make perforin granzyme A and B and granulysin, and that triggers fibroblast proliferation, and we believe that accounts for this distinctive storiform fibrosis in this disease. Note that IgG4 is out here in the periphery, and our thoughts about IgG4 is that it is probably serving a down-regulatory purpose, trying to down-regulate the ongoing immune response, and certainly not the primary driver of the response. So our current directions, we are actually beginning very soon a trial of an anti-CD19 therapy. I would love to do a worldwide trial of anti-CD20 therapy, but I haven't been able to raise enough interest in that. We're starting an anti-CD19 therapy now, which will target plasmablasts, a non-depleting anti-CD19 antibody. We also think that it makes great sense to target this CD4 killer cell, and some of the surface markers should make it targetable. And I'll confide in you, we are now finding this CD4 positive killer cell in other diseases. And we suspect that it is an important cell in a number of inflammatory and fibrotic diseases. And now that we've identified a cell that seems to be the driver that is clonally expanding or nearly clonally expanding, it makes sense as a longer-term project to try to figure out what that T cell receptor is seeing and what the initial antigenic trigger for the disease was. It may be different for every patient. So in conclusion, IgG4-related disease is a great mimicker. Oster called syphilis the great mimicker, and indeed it was. But in this era, IgG4-related disease, with its ability to affect just about every organ system, is really a marvelous mimicker of many things. Pathology is the key to diagnosis, and I really can't say this strongly enough. It's very important to sit at the microscope with the pathologist and experience this magical thing called clinical pathologic correlation, which is all too often overlooked these days. Plasmablasts are a very useful biomarker for this disease. B-cell depletion is effective through its effects probably on a novel T-cell population. And we believe that this, what we will learn from this disease is highly relevant to a lot of other immune-mediated conditions. So in closing, I would like to thank my laboratory colleagues who, with whom it remains such a great pleasure to work. Shiv Pillai, who I know has spoken at the University of Washington before, is a marvelous B-cell biologist, is now learning a lot about T-cells too, and his exceptionally talented postdoctoral fellows Hamid Matu and Vinay Mahajan. Thank you very much. I'd be delighted to try to answer any questions.